Good morning, everyone, again. I want to say thank you for joining our program today. Our session this morning is about chronic disease and management. So we have Dr. Damola Adeolu James, who is our main presenter today. I want to say thank you for being here with us. We'll see her very soon, having to take this presentation. And we have Dr. Moses Olakomi, who is also a doctor in Canada. Both of them are doctors in Canada. Saskatchewan to be precise. I would do a brief introduction. I'll start with our co-presenter, that is Dr. Moses Olakomi. So just give me a moment. So Dr. Moses Olakomi is an esteemed family physician in Canada that earned him a well-deserved, that is My Family Doctor Rocks 2023 award by the Saskatchewan College of Family Physicians. Dr. Moses graduated from medical school in 2005. He has been actively practicing as a family physician since 2006. He began his medical practice in Saskatchewan in 2014 and has since made significant contributions to the field. Throughout his career, Dr. Olakomi has consistently pursued professional development, achieving noteworthy credentials. He earned the Licentiate of Medical Council of Canada and obtained certification from the College of Family Physicians of Canada, showcasing his commitment to excellence in the medical field. So I want to say welcome, Dr. Moses Olakomi. He's our co-presenter today. But we would
Thank
not
you very
forget.
much. Yeah, good morning, everyone.
Good morning again on behalf of everyone. So I will not forget our main presenter here, that is Dr. Damola Adeolu James. She's very humble and I will not say too much of herself, but at least I know she's here to make this session very, very memorable and interactive. She has been practicing as a physician for 14 years now, with 4 of those years of practicing being in Saskatchewan. She has since obtained her certification by the College of Family Physicians in Canada. She's also happily married and blessed with 2 kids. I'm sorry, Dr. Moses, I didn't talk about your children. He's also blessed with children too in Canada. So I'll go back to Dr. Damola, and we are very proud of her Nigerian heritage. As for myself, I remain Oluwatosin Aileafen, your host. I'm an insurance independent broker, and I like to help my community one way or the other, sharing information, enlightening them either financially or either way that they need to be more informed about how the Canadian system works financially. But today we're talking about our health, and that is why I brought them to this matter, because my profession almost relates more to our health. Yes, we work hand in hand with doctors too when it comes to attending physician statements. And we see how our clients actually face some challenges when it comes to getting life insurance or getting critical illness protection plan or living benefits, because before they can get those kind of life plans, they need to know their medical history or their health history. So let's us give Dr. Damola Adeolu James the opportunity to educate us today, enlighten us today. Don't feel shy, please ask questions. This is going to be an interactive session, I believe so. Thank you again, and I'll give the floor to our doctor.
Good morning, Ms. Tosin. Nice to be here to share some of the information I have with everyone. It's a pleasure to be on this call this morning. She has kindly introduced me well, and I'm currently in Rosetown in rural Saskatchewan. Can you see my slides?
Very well, yes.
Okay, thank you. Right, so this morning we'll be talking on chronic diseases. It's important we talk about chronic diseases because it's a major cause of mortality, that's deaths and disability in Canada, especially in developed countries. So as a way of introduction, chronic diseases are conditions that occur and they last for at least 1 year before we call them chronic. So if we say chronic disease, that means it's been going on for at least 1 year. Usually they require ongoing medical attention, and they cause significant burden to the person that is affected by the condition and even the people around that person. Right, so they are the leading cause of death and disability, like I said, and it affects lifestyle because it changes a lot of things when people are diagnosed with chronic diseases. So what's the impact of chronic diseases on our health? It affects quality of life. Many people, once they get the diagnosis, it affects what they can do. It reduces how functioning they are, especially some people with chronic, musculoskeletal conditions. It affects their mobility. Towards the end of, the disease stage, especially when there are complications, they can make them dependent on other people for care, which in short affects the patient's quality of life. It also impacts emotional and psychological well-being. Most people with chronic diseases also have depression alongside with it because it's just like you're carrying a disease for life. It causes anxiety, and some people with so many comorbidities, like so many chronic diseases, can have increased risk of committing suicide. It also causes stress, on managing the illness, and as a result can cause other physical symptoms. It increases disability and death, like we talked about, and it's also a significant financial stress on the person affected and even the community and even the nation at large. So from the Preventative Health Association of Canada, they had found out that Canadian economy is affected by, at least the government spent $112 billion on managing chronic diseases. Cost incurred in the healthcare, cost incurred by absenteeism from work. So it causes a significant economic burden. It also, decreases work performance. Some people are at work and they are thinking of, what to expect from their next doctor's visit. So that's significant too. Global statistics, that's how many people in the world are affected by chronic diseases. According to WHO, they say it accounts for 71% of deaths globally, and that's quite significant. In Canada, 45% of Canadians live with at least one chronic disease. So that's like if you have 2 Canadians, at least one of them might have a chronic disease. And 1 in 12 have more than one chronic disease. And we'll see how this is important because most of these chronic diseases share the same risk factors. So if, for example, someone has hypertension, there is a high chance of developing problems with cholesterol, diabetes, and other chronic conditions. As people get older, they have a higher risk of developing chronic diseases. We should also note that it's getting commoner in younger population because of changes in our lifestyle. There's also changes or disparity in prevalence amongst some social demographic factors. For example, people that live in remote areas where there's poor access to health, like in rural areas or even on the reserve, First Nation reserve, there's a higher prevalence. People that are of low socioeconomic status too, they also have higher prevalence of chronic disease. People that are in urban centers, people that are educated, people that are exposed to information, usually they pick it up early and they can manage it early. And that is why, sessions like this are important to encourage and enlighten people on chronic diseases. So there are a lot of chronic diseases. If you see the picture I have here, cholesterol, problems with lipids or cholesterol, hypertension and other heart conditions, like heart attack, stroke, angina or chest pain, all of this comes under, cardiovascular diseases. Then we have diabetes, dyslipidemia. So when we say dyslipidemia means abnormal lipids, and lipids also means cholesterol. So issues with cholesterol. Then COPD, chronic obstructive pulmonary disease. This is like a chronic condition affecting the respiratory system. That's the lungs. Yeah, that's the lungs. So that's also a common chronic disease, especially in Canada. where people smoke a lot. Cancers, that's a major one. Different kinds of cancers account for higher percentage of deaths from chronic diseases. Diseases affecting the bones and the muscles. Arthritis is also a common cause, or one of the common chronic diseases we have. So, but for the sake of this presentation, we will talk on a few. I hope I'm not too fast. Am I too fast?
Not at all.
Okay, right. So we'll talk on hypertension. As many of us might be aware, hypertension also means high blood pressure. So the definition of hypertension is actually sustained elevated blood pressure. So when we say sustained, that means it's not just in one occasion. So the person needs to check the blood pressure more than once before we can say this person has hypertension. So we say sustained systolic blood pressure, which is greater than or equal to 140 millimeter of mercury, or the diastolic blood pressure more than or equal to 90 millimeter of mercury. So the systolic blood pressure in layman's term is the number or the figure we have above when we check the blood pressure, and the diastolic is the figure or the number that is below. So when we say 140/90, that's what it means. And like I said, it's sustained blood pressure. So before we make a diagnosis of hypertension, the person must check blood pressure on 2 different occasions. So for example, if someone checks the blood pressure now and it's 150/90 or 150/100, it's not enough to say this person has hypertension. We need to check it again on a second time, or a second clinic visit, or a second time at home. If the second one is still high, then we can say, okay, this person has hypertension. But there are some criteria to checking blood pressure, and this is important because so many people are mislabeled hypertensive because they don't check their blood pressure correctly. So first things first, blood pressure must be checked while the person is sitting down. Sitting down for at least 5 minutes, well rested on a chair. Both feet are on the floor. Arm is rested on a table or on a chair above the heart level. And then you also need to use the appropriate size blood pressure cuff, because all of these things can affect the reading of the blood pressure. The other thing is, it should be checked. Some people have a cup of coffee and then they check their blood pressure and it's high, then they begin to panic. So usually it's best to check when you've not had coffee for at least a couple hours. If someone smokes, we advise not to smoke before checking the blood pressure, So all these things needs to be put in place. So when this is done and the blood pressure is still more than 140/90, then we can say the person has hypertension. I will talk about white coat hypertension here, which is when someone goes to a healthcare facility or a doctor's office and the blood pressure is high. Sometimes that might not be the true reflection of what it is. So in that case, we advise the person to go back home, following all the listed recommendations, and check again at home. So home blood pressure might be better than office blood pressure, but I won't go into details about that, but just for us to be aware. So hypertension is common in Canada. 1 in 4 Canadians have high blood pressure. So according to the Canadian Task Force on Preventative Healthcare, it is recommended that everybody over 18 years of age should check their blood pressure at any doctor's visit. It could be people younger than 18 could check if there are risk factors. So from the Nigerian parlance, they say, oh, hypertension is a silent killer. And that's because usually people don't have symptoms of high blood pressure until complications start setting in. So there are risk factors for developing hypertension. I'll just mention a few here. Male gender have a higher prevalence of hypertension than their female counterparts, especially when they are younger. As people get older, the risk of developing hypertension increases. Smoking, high cholesterol, which is also dyslipidemia, obesity, that is when people are fat. If there is a family history of hypertension, some kind of medications can also increase the risk of developing high blood pressure, like steroids, for example. and some other medications. I won't bore us with that. Recreational drugs to increase, the risk of developing high blood pressure. So like I said, usually it's not symptomatic. It's just peaks when someone goes into a doctor's office for annual visits and, hey, this blood pressure is high. You come back a week later and it's high again. Then we say, okay, this is hypertension. On some rare occasions, people have complications, which could be acute or chronic complications. So high blood pressure commonly affects the heart. It can cause heart attack. It can cause what we call angina, which is a spectrum. It can affect the brain. Commonly, it can cause stroke. It can cause hemorrhage. That is when a vessel in the brain ruptures and bleeds. Hypertension can affect the kidneys. It can affect the blood vessels. So in managing hypertension, we'll talk more about the lifestyle management because all these chronic diseases have similar risk factors, have similar lifestyle management. So we'll talk about it towards the end of the presentation. But one thing I want us to note is that medications are important also in managing high blood pressure, and there are a whole bunch of medications we use. People tend to compare their pills with their friends. Oh, my friend has high blood pressure. She's taking this medication. Why am I not using this medication? People use medications based on different reasons. And that's why I put their comorbidities, and it is individualized. So for someone with diabetes and high blood pressure, their target blood pressure will be different from someone who is 20 with high blood pressure. So we should not compare notes or compare pills, with our friends. So that's important. Then once there's a diagnosis of hypertension, many times people might need to be on medications for life. Sometimes people might go off medications depending on how they can control their lifestyle, but most times people might need to be on medications for life. And it's important for them to follow up as scheduled with their family doctors, just to watch out for complications and manage any comorbidities. I'll talk on the lifestyle management later on in the presentation. So I will also talk about diabetes, which is high blood sugar. I'm sure many of us might be familiar with that. So diabetes is a metabolic condition that is due to deficiency of insulin. Insulin is an hormone in the body. So when this hormone is low, then the blood sugar is high for a long period of time. Usually people with diabetes early stages also don't have symptoms, but when they've had this diagnosis for a long time, they can have presentations like, getting thirsty excessively, needing to pee a lot, needing to drink water a lot, weight loss, weakness, fatigue, and all of that. So it is also recommended for people to check their blood sugar on a routine basis. According to the Canadian guidelines, everybody over 40 years of age should check their blood sugar level. If there is a risk factor, which we'll talk about, they might need to start checking their blood sugar earlier. Diabetes is also a common chronic disease in Canada. 30% of people live with diabetes or pre-diabetes. We can see here the complications from diabetes. It can cause stroke. It's a leading cause of blindness in the world, heart attack, kidney failure, and it can cause, non-healing leg ulcers or wounds in the leg that can ultimately lead to amputation. Risk factors for diabetes, we can see that it's similar to risk factors for hypertension, obesity, smoking, sedentary lifestyle. So that's when people don't move, people don't walk, people don't exercise, people prefer to sit. So that's sedentary lifestyle. Family history of diabetes is a risk factor. Some people in pregnancy have high blood sugar, gestational diabetes, and they can develop diabetes in the future. PCOS, medications also like steroids can cause high blood sugar, and race, it's commoner in Aboriginals and even in Black compared to Caucasians. So how do we diagnose diabetes? So when someone has symptoms, like I talked about, drinking a lot, peeing a lot, eating a lot, losing weight, all those symptoms, and we check their blood sugar. So RBG is random blood sugar. If we check their blood sugar just at any time, they go to the lab, maybe after a meal or during the day, they check their blood sugar and it's more than 11.1, then we can say that person has high blood sugar. So symptoms and a blood pressure reading that is high. But for someone that does not have symptoms, we need to check their blood sugar level on two, like they need to get two abnormal results. So the FBS is the fasting blood sugar, which is greater than 7. And then we call hemoglobin A1C, which is one of the parameters we check. If it's more than 6.5, then we can say they have diabetes. Diabetes also has complications that we talked about, like the picture that I showed previously. But sometimes people also present to the hospital with acute emergencies in which their blood sugar is acutely high. We call it hyperglycemic state. In that case, it's life-threatening. Some people can die if they're not properly managed acutely at that time. So management of diabetes, same with hypertension, lifestyle modification, which we will talk about, and then also medications to lower blood sugar. Medications can be oral pills. It could be injections like insulin or some newer medications that are available now in Canada and even all over the world. We'll talk about the lifestyle changes very soon. For people with diabetes, it's also important for them to follow up regularly, checking their blood sugar regularly. They might need to adjust medications as needed, like hypertension, so they need to be on medications almost for life. So we should take notes as well. Dyslipidemia, which is abnormal lipids or abnormal cholesterol, is also a chronic medical condition we want to talk about. People have, so it could be in different forms. There's something we call the good cholesterol and the bad cholesterol. So the good cholesterol is what we call HDL. The sources of this good cholesterol could be from plant fats like nuts, some, avocado, some fish. They are sources of good cholesterol. So some people have low good cholesterol. In that case, it's a problem. Some people have high bad cholesterol. It is also a problem. People have high triglyceride, which is like a storage form of cholesterol. So all of these abnormalities can present as dyslipidemia. Risk factors, same: inactivity, physical inactivity, unhealthy nutrition, obesity, diabetes, kidney disease, alcohol abuse, smoking. All of these are risk factors. So following the Canadian guidelines too, people over 40 should be screened. They should check their cholesterol at least once a year, once in 5 years, if there are no risk factors. But everybody over 40 should check it at least once. And treatment is similar: lifestyle modification and pills, medications to treat high cholesterol. I'll talk briefly on cancers here, basically focusing on guidelines for screening. Cancers, they're common in this part of the world. It's good because we have screening, methods that are free, unlike in Nigeria where people don't get screened. So we should make use of the opportunity we have here. So the common cancers I'll talk about, cervical cancer, which affects women. The guideline is for every woman sexually active over 25 years should get a pap test done every 3 years until they are 69 years of age. So we should take note of that. The other cancer is breast cancer. And for screening for breast cancer, mammogram is recommended. Every woman over 50 should get a mammogram at least every 2 to 3 years until they are 75. If there is a risk factor of breast cancer in the family, then they might need to start screening earlier than 50. The other cancer I'll talk about is colorectal cancer, and this is for everybody, male or female. It is recommended in Canada for everybody to get the FIT test. So it's called the fecal immunohistochemistry testing. So usually the government sends these kits to the homes of everybody over 50, and they do this every 2 years. This detects or picks colon cancer. Some other testing are available for colon cancer for people that have a risk factor. I won't talk about that. And then for prostate cancer, this affects men. The screening for prostate cancer is by testing the blood for what we call PSA. Screening is controversial, but if there is a risk factor of prostate cancer, if there's any member of the family with a prostate cancer, or people from African American heritage, it's recommended to get PSA testing done from the age of 50. All of these screening tests for cancer is very important because many people's life are saved by screening and early detection and treatments. When people don't get screened, the cancers would have advanced and sometimes it's too late to help them. So it's important for us to get all these screening tests done as recommended. Okay, now, so winding up, we'll talk about the management of chronic diseases in general. If we have, going back, we see that diet, physical activity, all of this play a role in developing chronic diseases. So the first lifestyle change people need to make, even if they don't have chronic diseases yet, to prevent developing chronic diseases, they need to adjust their diet. So we need to make changes to our diet. So the first one here is to reduce saturated fat and trans fat. So most times it's good when we go to the grocery stores, we can check the, the nutrition requirements and see how much of fat we have in what we are buying. So we need to avoid food that is rich in saturated fat, like red meat, full fat dairy products, processed food. So all these bad fats can make the bad cholesterol go up. Then we want to encourage people to increase their healthy fat intake. So I talked about plant-based fats like avocados, nuts, healthy fish like salmon, using olive oil for cooking. All of this can increase the good cholesterol in the body. Then we talked about fiber. We encourage people to increase their fiber intake. Sources of fiber, oats, beans, lentils, and vegetables and fruits. All of this would help reduce the bad cholesterol in the body. So it's important we increase fiber. According to the Canadian Food Guide, if you have a plate of meal, they want 1/4 of your plate to be from carbs like grains. And even when they talk about grains, whole grains rather than processed grains, whole wheat bread, whole rice grain rather than white bread, right? Then the other quarter should be protein, preferably lean protein. And the remaining half of the plate should be vegetables and fruits, that's the Canadian Food Guide. So we can, check that out and see how we can incorporate that into our daily diet. Then also we encourage people to increase their omega-3 fatty acid intake. Then limit refined sugar and processed carbs. This can increase the risk of developing diabetes and even hypertension. So that's important for us and for our children so that they can start healthy choices from a young age. Physical activities, the recommendation is for people to get at least 150 minutes of moderate intensity aerobic exercises per week. And this includes walking, swimming, cycling. So if people cannot, so sometimes we say 30 minutes per day, 5 minutes, 5 times a week. If you can't get up to 150 minutes a week, just start from where you are and, build up to until you get to the target. Or for some people that like the vigorous intensity exercise like walking or high intensity interval training, 75 minutes of these activities per week is recommended as the minimum. Of course, we can go higher if we can. So exercise can help reduce cholesterol. It helps reduce blood sugar. It helps reduce blood pressure. So it's important to be active. It's important to move our bodies. Then weight loss. Weight loss is very important as well. We talk about obesity when people have BMI of more than 30. So BMI is when we check someone's weight against their height. People with obesity also have a risk of developing all these chronic conditions. So no matter your weight, the recommendation is try and lose at least 5 to 10% of your weight. For someone weighing 100 kg, for example, it might be unrealistic for us to tell them to lose 40 kilograms. So losing 10% of 100 kg is still okay, can cause significant improvement in, health outcomes. So that's important. Smoking cessation, for some people that smoke, the recommendation is no smoking at all because it increases risk of cardiovascular diseases like hypertension, diabetes, cancers. So it's important for people not to smoke. Alcohol moderation. The recommendation is no alcohol at all, but if you have to drink, then for women, less than 10 drinks per week, not more than two drinks per day. And for men, less than 15 drinks per week, not more than 3 drinks per day. That's important as well. Other things that sometimes we don't take note of is stress management. Many people are stressed with work, trying to make ends meet and all of that. But it's important to take a break, to relax, get some, mindfulness training, relaxation techniques. Some people practice meditation, depending on what you believe, but it's important to manage stress. Getting good sleep as well comes into play here. Then we talk about behavioral therapy and support. So it's difficult, like we say, chronic diseases are lifelong. Sometimes it helps people when they see other people with their condition, then they can come together and encourage each other. So there are support groups for people with diabetes, support groups for people with hypertension, people with different kinds of cancers. They can encourage each other, support each other on changing their lifestyle, on adherence to medications and all of that. The most important aspect as well is need for regular follow-up and compliance with medication. For some people, once they have a diagnosis of high blood pressure or diabetes and they're on medications, they stop seeing the doctor. Like, oh, I'm using my pills, I'm fine. But that's not enough. It's good to check up regularly to be sure what you're using is still okay for your condition. It's important to be sure that there are no complications. Like we talked about, all of these conditions can lead to complications. So regular follow-up, medication compliance, checking with the doctor at least every 3 months or 3 to 6 months, depending on the level of control, is important. Right. So in conclusion, we've spoken about chronic diseases, talked about hypertension, diabetes, high cholesterol, and screening for cancers. All of this, we have seen that lifestyle changes play a significant role, even though there's a role for, genetics, like, a family history. For example, if someone in a family has hypertension or diabetes, there's a risk that other family members might develop it. However, if that person adopts a healthy lifestyle, they can change the narrative, right? So, lifestyle choices play a very important role in our well-being. And we've seen how chronic diseases can impact quality of life of the person and people around. So it's important we take caution and improve our well-being as much as we can. So this is where I will stop the presentation. Thank you for your time. We're open to questions now.
Thank you very much, Dr. Damola. That was very precise, on point. I know that this presentation could take a very long conversation, but your presentation was on point and very clear to the public listening. And so we have some questions in the chat. I also have my own questions too. But let me give the public here as our guest here the opportunity to read out there so you can hear this. I'll take the first one coming from Mr. Ken Okoji. Mr. Ken Okoji asked that what is the relationship between the cholesterol in nutrition facts on food products versus your body? That's one question. Should I take it again?
I think it's on the chat, right?
Yes, it's on the chat.
Yes,
What
yes.
is the, for those who are not reading, I want to read out. What's
Okay.
the relationship between the cholesterol in nutrition facts and on food products versus your body? It is advisable to eat. Is it advisable to eat or buy products with zero cholesterol?
Yeah, thank you. That's a good question. And, it's different from what we are used to from Nigeria, right? We just buy stuffs without checking. But yes, the information on the nutrition facts correlates with the cholesterol in our body. So if we pick, for example, maybe a pack of chips, we will see they say, okay, saturated fat 20%, trans fats 0% or 5%. So saturated fats and trans fats are the bad fats. Unsaturated fat is better. So for example, if we buy bacon, for example, we can be sure that bacon will have a lot of saturated and trans fat. If we now buy turkey bacon or lean meat bacon, we can compare and see the differences. So basically, what we eat correlates to what is in our blood, if that's a good summary. So if you consume a lot of saturated fat, a lot of cheese, a lot of bacon, a lot of high fat milk, it's just a matter of few months. The LDL cholesterol in the body will go up. So yes, it is better to buy products that have low saturated or trans fat, or no, low or zero, right? So I'm not sure of any meat product that has zero, but we want to check the percentage. So if you have something less, say 10% or 5% versus another product having 25% or 30%, we can be sure that which one is better than the other. So I hope that answers the question.
Yeah. Thank you, Dr. Hadiolu James. The presentation was concise and nice. Thank you. I want to talk about the cholesterol. We still need cholesterol in our body because cholesterol is used to make cell membranes. We talk about good and bad cholesterol. The LDL is the bad cholesterol. Yeah. And we always want to keep it down. We still need it. We always want to keep it down because high LDL might result into plaques that could block arteries, might result into stroke and heart attack. But we need HDL cholesterol. HDL cholesterol is the good cholesterol. And she mentioned the saturated and those monosaturated fats. When you look at the most food packages, they will tell you the amount of fat there. They could be converted to LDL and increase the LDL in our body. When we do blood tests, we only look at those. When you talk about cholesterol, it's not just one entity. It comes in different types. You have triglyceride, you have LDL cholesterol, you have HDL cholesterol. That's how we break it down. And we always want to have good, cholesterol, which is LDL. We always want to keep LDL down. When we start to have those food high in fatty component, and they tend to increase LDL, that's when the problem is. We just need to balance everything, portion, and ensure that we keep those kind of food. We'll still take them. It's just the portion that matters. Thank you.
So that was Dr. Moses Olakomi. Thank you for that additional information you added there. And I still want to go ahead with the next question coming from Mr. Ken Okuji. So his second question is, hold on. For breast cancer, this is related, it's in relation to breast cancer. For breast cancer, those with known history of breast cancer in their family should do the screening earlier. However, I understand or listened over the CBC health program, the advocacy for early screening for everyone, irrespective of family history, from age 40. What is your take on this?
Yes, thank you for that question. So in Canada now, the recommendation is breast cancer screening from age 40. However, if we know the health system in Canada is provincial, it's not just the government that controls what is happening in Saskatchewan or in Ontario. So I think some provinces already started screening everybody from age 40. But as we speak in Saskatchewan, it's still from age 50. But I think sooner than later, screening will start from age 40 in Saskatchewan as well. So yes, it's recommended now that everybody gets screened from age 40, but it's not yet Saskatchewan government funded. But if you want to pay, or if there's a risk factor, some people even get screened as early as age 30, depending on, the family history. Yeah.
Thank you for that. Dr. Moses, do you have anything to add to that?
Yeah, thank you, Tosi. Damola said it all, because that age bracket has been a controversial and a struggle situation. I know in BC, I was in BC last November. We have an advocacy group pushing. BC is one of the provinces leading that. The Canadian Task Force of Preventive Health Care, CTPHC, which we follow the guidelines, they still insist on using 50. But something that I want you people to understand is you need to look at amount of money government put into this screening. It could be political, and that's why I'm not going to go to that direction. But for Blacks, I've been an advocate of starting screening at age 40. And a lot of bodies are pushing to start screening women from age 40. I'm an advocate of that, and I still screen my patient from age 40 because we are picking a lot of cancer, breast cancers now, even between 40 and 50. Why not moving it down? Let's move the bar. Let's just lower the bar. 40 is okay, is appropriate, but you need to just have that discussion with your family doctor to discuss the risk and benefit. Because when you go there, they might want to stay with CTPHC guideline and say it's 50. Just have that discussion, and is very, very helpful. Secondly, is about some data from the US. The average Black man is likely has like 2 times prevalence of dying from cancer compared to their white counterpart. And that's why it's important for them to have their screening earlier. Even the colon cancer screening is recommended to start earlier. We don't need to wait till age 50. And those are the things we need to start discussing in our community, some of our clients, and also we want to also push in such a way that throughout the country, we have this guideline separate or push it down, because from the data they are using or the data they use to make these guidelines, I'm not sure if Black population were accounted for. And that's why we need to look at this critically. Thank you.
Thank you, Dr. Moses. I see Mr. Ken Okoji has another question. I'll permit you to speak now, though you still have one in the chat. So, Mr. Ken, you can unmute yourself and please speak.
Well, thank you so much for this webinar. I mean, health is a priority, given the environment that we live in, and generally with what is the lifestyle changes that we've experienced in the past decades. So I jump on any opportunity to listen about how to maximize your health concerns. So thank you very much for putting this up.
Awesome.
And I want to thank also the doctors for sharing very insightful informations that will help us improve our health status. Coming back to Dr. Damola's comments on cancer, colonoscopy, I just hit 50, so you might as well understand why health is important for me. And I think I had that pack that was sent by the government to check for colon cancer. But I went a step further, even with my doctor saying, you're okay, don't worry. I insisted that I need to do the colonoscopy test and also the endoscopy test, I think. which I have done that. Can you throw more light? Because like you said, it's important in our community to have the African community, so to speak, to have this awareness that we're more prevalent to cancer compared to the other races. I want your take on what the community, especially the medical community, from the Black community, is doing to push this further. Because when I had this conversation with my white doctor, he kind of pushed it off, but I insisted because I've read several journals about our susceptibility to health challenges as men, so to speak. So, Dr. Dermola and my doctor lady. I mean, sorry, what's the gentleman who spoke very
Dr. Moses and
Moses, awesome.
Damola.
Yeah, awesome. Can you guys just throw more light on what you are doing as medical practitioners in the Black community to push this thing about cancer awareness? Thank you.
Yeah, thank you, Mr. Ken, for that question. It's good to know that people are aware of their health and want to get the best opportunity available. So like Dr. Moses mentioned, screening. So screening is for people that don't have symptoms. Screening is for the general public. Screening is for everybody. But once there is a symptom or a history in the family, then we take it to a higher level. Now, the screening for colon cancer is for everybody over 50. There are two approved screening methods for everybody over 50. The first one is the FIT test, which you talked about, and the second one is the flexible sigmoidoscopy. There's also what we call a colonoscopy. So if someone is getting the FIT test, for example, they check that every 2 years. Basically, the FIT test just see if there is blood in the stool, such that if the FIT test comes back positive to show blood, then they send that person for a colonoscopy, which is more specific. Now, everybody cannot get a colonoscopy. It is not realistic because there are just a few specialists that does this colonoscopy, and they can't be pushing the probe into everybody's, so that's why the FIT test seems to be the easily accessible and cost-effective screening method, right? So it depends on what is available, really. And also because health is free or insured, the government will want to choose what is more cost-effective, right? So it's very okay for you to insist that, no, I don't want a FIT test. I want to do the flexible sigmoidoscopy, or I want to get a colonoscopy. It's fine, but everybody cannot get it. So that's what I'll say. I think Dr. Moses can shed more light on that.
Thank you, Dr. Adelu James. You just nailed it on the head. It's all about the cost, okay? And let's look at this. We start to throw colonoscopy to everyone. It's going to strain the healthcare cost. And we're in a system where we use universal healthcare system, not like the US where you can choose to have more insurance that can cover you privately, or like the UK where you can choose NHS or you can go privately. And we have similar situation in Nigeria, okay? But in Canada is more universal, and I know there have been calls of pushing or advocacy for us to introduce more private where people can go easily to have this done. And that's my line of thought. If you choose to go for colonoscopy or flexible sigmoidoscopy, have that discussion with your doctor. Yeah, it's always good to have that. This is what I prefer, okay? And most of my Black patients above 40, even when they come, say, oh, even those with average risk, let's say mom or dad had colon cancer at age 80, 75, they're still average risk, okay? I'll say, no problem. I can send you for FIT test, but what do you prefer? Some say, I want colonoscopy referral. Yeah, I'll do the referral. Now, depends whether they get in on time or not. Sometimes they can be on the wait list for 12 months. But one thing I want you to know is even the US, United States Task Force of Preventive, Healthcare, UST we can check it. There's been a push, there's been a fight about this, and they try to lower that screening age to 45 now. Okay, and some group are still pushing to lower the screening age for Black community, but is not taken yet. In Canada, we're staying with 50. US, they moved there to 45. But you still have that room to add that discussion. Some of the people that do know, they do come and say, oh, I want to have this colonoscopy screening or sigmoidoscopy. Yeah, we'll refer. And I think Mr. Koji, as you said, it's good to be aware, it's good to be informed, and that one will help your decision when you are with the family doctor. And I think you've taken the right decision by asking. Okay? Yeah, thank you.
Thank you very much. Thank you. I have my own question. Before I go back to Mr. Koji's questions, because we're going to change the topic, I would like to ask if there's any other person that has a question to ask, please do so. Do ask. So my question has to do with hypertension. I know that many people are exposed, or rather have high blood pressure. High blood pressure is what is the emphasis. What of those with low blood pressure? Who's more at risk? And how can one with low blood pressure be able to manage this?
Okay, thank you for that question. Some people have their blood pressure naturally low. So when someone says low blood pressure, the first question I would ask is, how low is low? Is it less than 90/60? If that is the case, then yes, we might need to find out why it is that low. Some people naturally, so any blood pressure more than 90/60 is okay, as long as the person is not on any medications to lower blood pressure, as long as the person does not have symptoms of low blood pressure, like dizziness, feeling faint, feeling lightheaded. Those are some symptoms of low blood pressure. It could be caused from over medication with high blood pressure. It could be caused from dehydration. It could be caused from, stress, not sleeping well, or just a natural thing for that person. So, usually low blood pressure, if it's normal for someone, does not really cause much problems. Like, it doesn't cause any cardiovascular risk other than dizziness, feeling faint, risk of falls, and all of that. But if it's an elderly person, like someone over 70, over 80, having low blood pressure, and the person is not on medications, the person is otherwise healthy, then it's reasonable for the person to see a doctor, right? And make sure there's nothing going on. So I'm not sure if that's answered the question. I'm not sure if Dr. Moses has anything.
So Dr. Moses, do you have anything to add to that before
I think I'm not going to add anything.
Okay.
It's been said. Thank you.
Thank you. Thank you, doctor. So my question also has to do with that issue of when you said some people have to take medication for life. What risk are they exposed to? Is it going to be affecting their liver or something? Because that is another concern personally for me. When I was having a case where we had to take medication for a long time, I said, this is a risk for one's liver. What do you say about that?
Yes, so everything in life is a risk. That's what I tell people. So which risk do you prefer, right? Risk of having high blood, right? Everything has side effects. Tylenol's got side effects. Too much of food, too much of sleep, too much of everything is got side effects. But what are the benefits versus the risk? Is the risk something I can cope with, or is it something I can say no to? For example, someone with high blood pressure, we start on medications. The person is working so hard on improving their lifestyle. Over time, the blood pressure is controlled. We lower the medication, the blood pressure is controlled. We stop the medication, the blood pressure is controlled. Then that person is good, right? It doesn't have to be on medications for life. But many people, once they're on medications, they're like, oh, yes, that's a quick fix, right? They still live their life. In such a case, they might need to be on medications for life. Right. So medications got side effects, right? That's why it's also good to check with your doctor frequently and get routine blood work done to see For example, some of this medication might affect the kidneys, right? So that's why you need to be checking to be sure you're still safe on the medications. But overall, the benefits outweighs the risks.
Okay, thank
Yeah.
you for that. Thank you. So there's another question from Mr. Wale Ajibola. He says, still on blood pressure. Does that mean some people's blood pressure could be higher than other
Oh, yes.
normally?
Yes.
Okay.
Some people are just low blood pressure, as if I can say that word. Naturally, some people run at 160, 90, 60, and we see them, like you see a 70-year-old woman and her blood pressure is 95, 60. I'm like, oh, your blood pressure is low. She's like, oh, that's the way it's been since I was 20. And she's not on medication. So that is the way she is, right? And some people with the high family history of high blood pressure, they've been struggling for so long. So it's not common, but yeah, some people naturally have a low blood pressure. So when we say low, it's not less than 90, 60. It's just mid-range.
Okay.
Yeah.
We'll be rounding up very soon, maybe next 7 to 8 minutes, because we started 10 to 8 minutes later. So there's still one more question from Mr. Ken Ukoji. I'll be reading that soon, but I want to still ask my question as regards cancer. So for those who, I know in Canada here, we get these mails that says, oh, go come for pap test. And I still spoke with a friend today that said she had that mail come to her several times. She has ignored it because she doesn't want to go. So what's the risk, aside the fact that if she has it, but in terms of if she doesn't go, what will Canada do about that? Is it going to be like, it's meant to be compulsory that everybody goes for pap test and they do go, and then there's going to be a repercussion for not going? And if one has cervical cancer, there is now going to be a blame or a court case or something. What do you say about those letters that come to all
Right.
the...
Yeah, that's a good question. So Canada is liberal. There's a freedom of, you have a freedom to do whatever you want. If you see, for example, you have someone in the hospital dying, the person can say, no, I want to die, as long as they know the person is competent, right? They allow the person die. So nobody will come and pick you up for not getting screened. Nobody will look down on you for not getting your pap test done. Some people know they have cancer and they don't get treated until they are almost dead. Then they will come and we start all over again. So in Canada, wherever you are, they will meet you there. Even though it's not good, but we recommend, screening, which I would strongly encourage that person to get it done. I mean, it's just 1 minute procedure, right? So it's better to get it done, but nobody would do nothing to you if you choose not to. Your health is your choice.
Yes, correct. Thank you. So last question. Oh, I'm seeing another question coming up. Please pardon me for my question coming in now. So as regards breast cancer, a family history has had cancer, maybe it has never existed before, and all of a sudden, maybe one of the family member had cancer, maybe the mother or some breast cancer. Now, what it's advisable for the females to go for that mammogram test. And then one now says that, okay, this woman is now has conceived. What is the chances of her, what risk is she exposed to if she doesn't go for such tests? And is it true that those who are into breastfeeding, so as I heard, have a lesser risk of having breast cancer? So that's two questions.
Okay. Yes, thanks for that question. So I will start from the last question. Yes, in a way, breastfeeding protects against breast cancer. And because breast cancer there's a role of hormones in developing breast cancer. Of course, it's not the only risk for developing breast cancer, but it's one of the many risks, right? So for some people don't breastfeed, right? And they don't have breast cancer. Some people breastfeed and they do have breast cancer. So there's no one answer to that. But yes, breastfeeding protects against developing breast cancer, but it doesn't mean people who breastfeed cannot have breast cancer.
Okay, thank you for
Okay.
that. Questions are coming in. So do you have
Okay,
something else to add?
okay, answering them fast then. Then the first question, like for example, there's a family history of breast cancer. Maybe there's a 30-year-old girl whose mom had breast cancer at 50.
Mm.
Then or let's say a 20-year-old girl whose mom had breast cancer at 40, that is uncommon, that is unusual. So in that 40-year-old woman, they want to do some genetic testing to see if she's carrying a particular gene that will predispose other offsprings of developing breast cancer. That 20-year-old girl will be subjected to getting that testing done, BRCA gene, right? So it is in such a case, if there's early breast cancer, yes, every female in that first generation or that family tree should be screened early for breast cancer. I don't know if that answers your question.
It does. It does.
Mhm.
To an extent, though. I want to just read everybody's questions now because they're
Okay.
coming in now. So, Mr. Ken Okoji asked, what is the relationship between red wine and improving the condition of heart? Is it a myth or reality?
Well, science keeps evolving. People keep doing research and people keep getting different outcomes, right? Initially, they say, oh, red wine keeps the heart healthy or whatever. But as at last year, Canadian guidelines says no alcohol is better, right? But if you have to drink, then this is what you should do. So I wouldn't say yes, I wouldn't say no. I hope that
Yes,
answers the
that's
question.
staying safe. You're speaking safe. Okay. Akanji, that's Deju. Please pardon me if I didn't pronounce that right. Deju Akanji. Thank you for your question. He says, or she says, could you please talk about detoxing the liver? I believe so many issues start with the toxin, with the toxins we expose our bodies to. No matter the healthy food we consume, there is waste we need to get rid of appropriately. Just a light on it, please.
Hmm. Well, so the liver is one of the organs that helps take care of waste products from the body. The kidney is also one of them, right? So detoxifying the liver, I don't know what you mean. Is it by using some medication?
Related to chronic diseases and management.
Hmm. Well, detoxifying the liver, I'm not sure if this is the right thing to say in this gathering, but from the medical parlance, there's no such thing as detoxifying the liver. But for some people into naturopath, some Chinese medicine and all of that, they talk about detoxifying the liver. Yes, most of the medications we use are metabolized in the liver. Healthy liver detoxifies itself, but a liver that is damaged might need help in detoxifying it. So, like she talked about, toxins are everywhere. The kidneys, for example, also detoxifies the blood. So, I would say detoxifying the liver is a myth, but some people believe in it. As long as you're healthy, as long as you don't have any chronic disease, then your liver should be functioning well. Maybe Dr. Moses can help with that.
Thank you, Dr. Adeolu James. When it comes to liver, kidneys, and those vital organs, we don't have any guidelines or any research backing detoxification. What we know that when they are functioning well, they take care of things. And that's why we need to be conversant and we need to be careful on what we put into our body. Okay. No matter the medication, when you take the right doses of medication, not more than what was prescribed, like Tylenol now, if you take more than 4,000 milligrams a day, there will be a greater damage to the liver, okay? And also we have some medication, when you start to taking too much of it, it has effect on the kidney too. That's why we are appropriate dosing, because these are based on research and a lot of things that pharmaceutical companies have done. And when it comes to detoxification of liver and kidneys, well, it's not something that I'm used to or I've read in my medical books or literatures. She said, yes, a lot of people are coming with things. They show me that, oh, our body to detoxify. There's something I always tell them, discuss with your pharmacist. Take this to your pharmacist, show them, and ask for interactions with the medication you are taking presently. Because a lot of things we take into our body also interact with some medication that we use. And we have to be careful. You want to detoxify, but remember, those stuff you are taking to detoxify, they still have to go through the liver. How safe are they? I don't think I have any research or any literature to back liver or kidney detoxification. Thank you.
Thank you, Dr. Moses, and thank you, Dr. Damola. We have Jara. Our hands are up, so you can unmute yourself and speak. I'll still have other questions in the chat. We're trying to round up very soon, so you can speak, please.
Thank you so much. Can you hear me?
Yes, yes. Please go ahead.
Thank you so much. I don't know how that Jara got in there, but my name is Professor Joy Olotu.
Welcome, madam.
I'm a professor of reproductive health, and I have taught anatomy, physiology in the medical school for about 25 years. I just wanted to pitch in with what Deju was trying to say about detoxification. I guess as a clinical research person myself, or as a scientist, there's this common thing in the human body that is referred to as antioxidant. I mean, what's that word now? Antioxidants, right?
Antioxidant.
What?
Oxidants.
The antioxidant.
Yes, antioxidants. Thank you very much. And especially living in the Western world like this, we seem to accumulate a lot of this. And I think that is what she is trying to say. How do we get this out of the system? Because the thing is that your liver, your kidney, in fact, the liver is like the first point of call, right? When anything comes into the body, if you look at the blood circulation of the integuments, of the gastroenteric system, the liver is where everything gets to first. So how do we ensure that we take care of the liver, we clean it so that we can have optimum health? I think that's what she was trying to say.
Okay.
I just wanted to shed more light on that.
Thank you very much, Professor Joy.
Thank you, Prof, for what you just said. As we practice in Canada and the US. Most time we follow guidelines, and sometimes when we come online like this, we always want to say something more research-based. I've seen a lot, and as I said, Canada is liberal, where people can choose to go natural pathway or come to medical. And in my practice in Canada for over 10 years, I've never told any of my patients, don't take that. I always tell them, please read more, talk to the pharmacist, and it works because they have right to choose things to do. But until we put in our guidelines that this is what we have to do, that's when, as medical doctors, we start to say it, or when we have something that is research-based, the evidence, we call it evidence. Thank you.
Thank you, Dr. Moses. We still have 2 questions or 3. Please, if you permit. Dr. Damola, Dr. Moses, please permit. Grace is asking here, thank you for the presentation, she says, just a bit of digression. How can one best treat vertigo after taking medications, but symptoms persist?
Well, I would say the person should see a doctor. I can't give any advice here.
Okay, thank you for that.
The other thing is, if the vertigo persists, you've seen your family doctor, they've prescribed medication. Because when we talk about vertigo, are we talking about peripheral vertigo or central? That's why it's important to go back to your family doctor to refer you to ear, nose, and throat, or to refer you to a neurologist. Thank you.
Thank you for that advice. Bimbola is asking, if someone was on blood pressure medication for about 8 months last year and later stopped taking it, what should such a person watch out for when trying to get pregnant?
So my question is, was the person diagnosed with hypertension? Or why did the person use for 8 months and stop? Was the blood pressure back to normal? Right? So There are some blood pressure medications that are safe in pregnancy, and there are some that are not safe in pregnancy. It's important for someone that has high blood pressure before pregnancy to see and be in close touch with the family doctor when pregnant, because there is a very high chance of having high blood pressure when the person is pregnant and needs to be treated. Otherwise, there's risk of complications to the mother and to the baby. So if someone with high blood pressure in the past was on medication and stops taking medication, is planning to get pregnant, the first thing is to go back to the doctor and be assessed, know where the blood pressure is at, know if there is any risk, and, follow advice as necessary.
Noted. Thank you. For the last question now, does IVF have any correlation with cancer? That's our last question for today. Coming from Wale Ajibola, does IVF has any correlation with cancer?
Well, from the little knowledge I have, I wouldn't say I have a lot of knowledge on IVF. I would say no. Just because IVF is helping people conceive, right? From the way the procedure is done, you get the people involved, you get their eggs and their sperms, and they get fertilized, and it is then, transferred into the woman. Looking at the process, it shouldn't increase the risk of cancer. However, there might be some medications they need to use before IVF is done. It depends on what kind of medication is being prescribed and for how long. Most times, these medications are safe. However, it is better for the person to check with the IVF specialists. So that's what I would say. I don't know if Dr. Olakomi wants to say something there.
Yeah, I don't have any evidence to link IVF to cancer risk. Presently, I've not come across that. Thank you.
All right. We've come to the end of this session. I want to say thank you.
So before we go, I just have to make a comment quickly. I know time is past spent. It's about stress that Dr. Damola mentioned. And that's something that we don't look at critically. One of the things that worsens situation in chronic medical conditions is stress. And we need to know how to deal with stress, especially because it will increase adrenaline, which will increase high blood pressure, and also cortisol, which will increase our glycemic state. Those are the situations we need to look at. I think I will stop there, and we can find time maybe next time to talk more about stress and how we can leverage on care coordination and some other things. Thank you.
Right. Thank you very much, Dr. Moses and Dr. Damola. We really appreciate this session, and I know that more people want to have this kind of session another time. Hopefully, we have this again very soon, maybe once quarterly or once bi-monthly, hopefully. But to get our doctors to come and have this kind of session with us, they are very busy, and we want to appreciate them for being here with us. Having two in this session was, I said, God blessed us. So thank you again, and thank you everyone for your patience. I know that we took a lot of time. There are still more questions that may come in, but let's call this a wrap and say God bless you all as we all live our lives and manage our health and those around us too. We hope to have a good report when we meet again next time. God bless.